Good morning, everyone. Today we will be looking at pragmatic clinical trials. What do we mean by the word pragmatic? To simply put, pragmatic means being practical. So these are trials which have real world effectiveness. They simulate the real world scenario as opposed to explanatory trials which have a very strict study design, follow strict protocol. They follow steps of randomization, blinding, allocation, concealment. The intervention of the study drug is ensured that it is given to administered to the patient, which may not be the case always. Say, for example, you want to study the effectiveness of a drug for diabetes. A pragmatic trial it would be something which would be done in an outpatient setting where the drug is administered to the patient, and then you look at the effectiveness and outcomes. In this case, adherence to the drug cannot be assured all the time because patients are not always 100% compliant with the drugs. As opposed to a explanatory trial, which the drug is made sure that the patient is receives the drug or the intervention. This is just a simple way to explain pragmatic and explanatory trials. So pragmatic trials have real world effectiveness. They help to choose between different care options and they have true benefit to the community. As opposed to explanatory trials which follow strict study designs and have high internal validity but poor generalizability. Um, so there are five stage steps in translational research, where the step one T0 is where basic science and research is involved and defining of mechanisms, targets, and lead molecules are done. Moving on to the final step, which is T4, where there is true benefit to the society from the uh, intervention. So, pragmatic clinical trials come under T3 to T4 of translational research. And then in the translational pathway, the study design moves from explanatory to pragmatic. And explanatory trials are those which are done in ideal conditions, and pragmatic trials are those which are done in routine practice. So, by explanatory trials, we mean the question we're trying to answer is, can this treatment work? It's a study looking at efficacy of the intervention as opposed to pragmatic trials, which look at, does the treatment really work in clinical practice. Let's move on to the case scenario that has been given today. So this is a scenario where there are a lot of refugees living in Vellore due to a recent natural disaster. So after this, you see that these patients have higher incidence of depression, anxiety, and post-traumatic stress, and you wonder if there are any digital health intervention which can help in reducing these issues in these people, and you find this trial. So this is a study which has looked at the effectiveness of a WHO guided digital health intervention for depression in Syrian refugees who were living in Lebanon. This is a randomized controlled trial. We will now critically appraise this using a CASP checklist. So there are four sections. So section A is the basic study design valid for a randomized controlled trial. The first question is, did the study address a clearly focused research question? Yes, it was a single blind, two-arm randomized controlled trial. The aim of the study was to test the efficacy of this digital tool. I will be talking about this in subsequent slides. Efficacy in reducing depression and displaced people from Syria who were living in Lebanon. Um, and this was developed by WHO. The PICOT statement, population included people who are from Syria, who have been displaced and were currently living in Lebanon. So the intervention is called step by step. So this was a 5-session guided intervention program designed to treat depression. The control was enhanced care as usual. I will talk about this subsequently in detail. So the outcome which I had looked at were depressive symptoms, which was measured by the patient health questionnaire PHQ-9, and functional impairment measured by the WHO-12. And these were measured at baseline, 8 weeks after baseline, after the intervention, 8 weeks after intervention, and at follow-up, which was at 3 months. And the time period of this study was from December to 2009 to July 2020. So the population studied were Syrian displaced people who were above 18 years of age living in Lebanon who understood either Arabic or English and had access to an internet connected device. And they defined depression as PHQ-9 questionnaire score of more than 10 or a functional impairment based on food as 12 scored more than 16, and the only people who have been excluded were those who had an imminent risk of suicide based on the PHQ-9 questionnaire, which had one question where whether the patient had any uh, depressive suicidal thoughts, and if they had answered yes to that question, then they were immediately referred to a mental health care center. As we can see here, it's very clear they have included this as a very big inclusion criteria and a narrow exclusion criteria, which makes this trial more pragmatic. So this is a PHQ-9 questionnaire, and so this has 9 questions. The last one is the question on suicidal ideation, and if there was a positive answer for this, then they were immediately referred to a mental health care center. And a score of more than 10 was considered to be, so out of 20, 27, score of more than 10 was considered to be those patients were included in the study. The next is this who does 2.0. Again, this is a test of functional impairment, and a score of more than 16 was considered to be positive, and these patients were included in the study. So the intervention is called Step by Step, which was a 5-session intervention designed to treat depression. This was um, in connection through an internet connected device through a browser or a separate app. So this step by step was accessible, and it provides psychoeducation and training for behavioral activation through illustrated narrative. It helped in stress management. It had a gratitude exercise, positive self talk, and helped in strengthening social support. The control group received enhanced care as usual, which included basic psychoeducation, and this initial psychoeducation was through the step-by-step app, and after that, if the screening revealed presence of depression or functional impairment, they were then referred to my evidence-based care, meaning healthcare centers where they were given evidence-based mental health care. Outcome measures, the primary outcomes were depressive symptoms measured by the PHQ-9 and HUDAS, and they had the response was considered to be 50% reduction in PHQ-9 symptoms and complete remission if the score was less than 5 on PHQ-9 questionnaire. Secondary outcomes which I had looked at were subjective well-being, anxiety, and post-traumatic stress assessed by these other questionnaires which have been mentioned here. So moving on to the second question, was the assignment of participants to the intervention randomized? Yes, so permuted block randomization with allocation or 1:1 allocation ratio was done. So by block randomization, we mean the as the patients are enrolled into the trial to intervention control arm, this is done in blocks of size varying between 2 to 8. This is done to ensure that adequate number of patients are there in both intervention and control arm, and there is no significant difference between the two groups. Randomization concealment. So the allocation concealment details was not clearly provided with the there were sealed envelopes based on which the uh, patients were allocated by the investigators into intervention and control arm. So were all the participants who entered the study accounted for at conclusion? Yes. So intention to treat analysis was done. They were analyzed in the same arm in which they were randomized. So this is a consort diagram showing the study flow. So the number of patients who were initially assessed for eligibility were 1,380, out of which based on the exclusion criteria for age, the symptoms, and suicidality, the number of patients excluded were 620 and 760 were enrolled. And the initial baseline assessment of PHQ and HUDAS was not completed by a few who were then excluded. And finally, 569 people were randomized, 283 to the intervention arm, and 286 to the control arm. But after this, there was a significant number of patients who were lost to follow-up. 153 in the intervention arm, 153 plus 1 plus 14 in the intervention arm, and 110 plus 23 in the control arm. So the number of patients who were finally who completed the final follow-up, the 3-month follow-up was very low. And the dropout rate was very high, with 59% in the intervention arm and 46% in the control arm. However, intention to treat analysis was done at the end. Was the trial stopped prematurely? No. The patients were analyzed in the groups in which they were randomized. Coming to section B, was the study methodologically sound? So to what extent was the study blinded? So it was a single blind study. So the patients, clinicians, and the data collectors were not blinded, and only the outcome and assessors and data analysts were blinded. Were the study group similar at the start of the randomized control trial? So the baseline characteristics of the intervention and control group has been provided. So as we can see here, most of the important factors are all matched between the intervention and the control arm, except for female gender, which was found to be 5% more in the intervention arm as compared to the control arm. Apart from that, age, marital status, education status, employment status were all found to be matched between the intervention arm and the control arm. So the next question was sample size calculation. So here we look at sample size calculation. The reference study which they had taken was a systematic review, and the effect size calculated in the systematic review was a standardized mean difference. The standardized mean difference is calculated as mean difference divided by standard deviation, and this is commonly used in systematic reviews, where the different studies which are included in the systematic review have different questionnaires, different scores, which cannot be compared right away. So standardized mean difference is one way of assessing effect size in systematic review, since the same measure was used in this trial to calculate sample size. They have taken 90% power and a 5% alpha error, and they have accounted for a high dropout rate, um, uh, which uh, which is most likely probably going to be the scenario in this case, because in a refugee status, the likelihood of somebody being accountable and being following through on this um, study was less likely, and we expect a high dropout rate, and they have accounted for it, which was correct. So the sample size was calculated to be 568 participants. Coming to the results, were the effects of intervention reported comprehensively? So before looking at this table, I want us to look at this table, which shows the results of the scores, the mean and standard deviation of scores of PHQ and HUDAS, which we will just look at the primary outcome now, of the intervention control arm at baseline, post test 8 weeks, and at 3-month follow-up. So here we see that the number of patients in the intervention and control arm is different from the actual numbers. And uh, both at the baseline, post 8 weeks posted, and 3 post test, and 3-month follow-up. So so here we have the value of PHQ-9, the mean value, and the standard deviation in the intervention group and the control group, and based on this we can calculate the mean difference, which is uh, 16.39 minus 16.37.02, and standard deviation is mean difference divided standardized mean difference, which was the effect size which was calculated, will be calculated as mean difference divided by standard deviation, which will be 0.02 divided by the standard deviation. The average of the standard deviation can be taken, let's say 4.2. So we will be able to calculate a standardized mean difference. But the problem here is that the number of patients in each of these groups are different from the actual numbers which were enrolled in the study. So the reliability of this table itself is questionable. So based on the results of this value, they have calculated the uh, effect estimates, which was the standardized mean difference, which I just explained, and the uh, effect size with 95% confidence interval. So here they also this model 1 and model 2 that has been explained here is something called imputation. So for the missing values, for like as we saw earlier, there was a high dropout rate in both the intervention and control arm. So if the dropout rate is high, something called imputation analysis is done. So by imputation analysis, what we mean is that the missing values are replaced by random numbers, and two models of analysis is done. One is missing completely at random and one is missing not at random. So here the model one had the imputation was done taking missing completely at random, and model 2 this RFLB, which is random forest Lee bounds procedure. Based on this, the missing not at random was taken, and in this the lower bound and upper bound is basically lower bound is worst case scenario and upper bound is best case scenario, meaning so imputation in general, what it means is that um, the missing values are replaced by random numbers, and we see uh, if the missing values will in the end affect the outcome. Say, for example, in the intervention arm, there are more number of females who have dropped out, and then we put values in the intervention arm be as bad outcome, and the control arm has good outcome, and this would be lower bound, meaning missing not at random with the worst case scenario. So this way different models are done, and at the end, if there is no significant difference in the outcome at the end of imputation analysis, then we can say that the significant dropout rate and the missing values are not significant, and that they are not significantly affecting the outcome. But here only two models have been done, and the values based on which the imputation and all had been done is not reliable because the numbers are different from the actual numbers. So the reliability of this table is also questionable. However, based on the imputation statistics also, they had found a significant effect size with a p-value of less than 0.01 and a effect size of 0.48 for depression, and for who has functional impairment, again effect size of 0.35 at 3 months and also at 8 weeks follow-up. The secondary outcome again, here we look at, they have given values for both response and complete remission. Response they had said as 50% reduction in the PHQ-9 score, and complete remission is value of less than 5. So in the intention to treat analysis for complete response, for response, let's say for complete remission, they have set a odds ratio of 5.1, meaning that using the digital mental health intervention step by step, there is a 5.1 times higher probability of complete remission using the step by step app as compared to not using. And the treatment, the incidence of remission in the treatment group was much higher than in the control group, 20% in the intervention arm and 44.9% in the control arm, with the odds ratio of 5.1. Using this, number needed to treat also can be calculated. Was the precision of estimate of the intervention or the treatment effect reported. Yes, so the precision, by this we mean the 95% confidence interval. Here in the 95% confidence interval, we look at whether the interval is narrow and whether it is crossing 1 or not. So here we can see that the 95% confidence interval in the treatment effect for response was narrow, whereas for complete remission, it was a wide confidence interval, indicating that it was not so precise. However, both the values did not cross 1, meaning that both are significant. But the benefit of experimental intervention outweigh the harms and cost. Um, so the harm, there is no known harm with the intervention because it is simply a app which helps, it's a guided app for mental health, depression and anxiety. The cost also, it's a freely accessible intervention with uh, no cost involved in use in application of the app in these patients. However, they had these e-helpers who are people who had background in mental health and education, who had training, and these people helped in help the patients or the participants in accessing the app and making sure that they follow through with the app, and they administered help them complete the questionnaires, facilitated the process of completing the questionnaires in 8 weeks and 3 months. So training of e-helpers is one more process which would have costed um, contributed to cost, and also all the patients who had completed all the questionnaires received a $20 phone credit. So this again would have costed, to translating it to Indian rupees, it was cost coming to around 4.46 lakhs. So fourth section is, will the results help locally? So now we will move on to something called the precise tool to look at applicability of the study in a local context. So precise 2 is stands for pragmatic and explanatory continuum indicator summary, which is precise 2. So the precise 1 has currently been updated, and this has 9 sections, and each of these sections have a each of the domain have a 5-point scale. So point 1 mean being very explanatory, as opposed to point 5 being very pragmatic, and based on looking at each domain, we assess the study and provide and give them a mark. So here the picture A is a representation of an explanatory trial in the precise tool, where the web appears pretty shrunken and narrow, as opposed to the second picture B, which is the representation of a pragmatic trial, which appears widened out and big. So in our study, the for we will I have given the scoring, and I will explain why I have given the scoring for each domain. So for eligibility criteria, applicability in our population, our patient population will also be similar. However, access to an internet connected device in refugees will be difficult, and also availability in local language will also be difficult. And uh, recruitment path. So I've given a score of 3 here, because the recruitment here took place through advertising on social media platforms, through WhatsApp, broadcast, through Facebook and Instagram, and not as a normal healthcare, as a patient seeking healthcare as a in a normal manner. So a lot of extra advertisements and broadcast had to be done. So I have given a lower score. Setting, the study setting was similar to our scenarios. I've given a score of 5, and intervention required these e-helpers that I talked about earlier, who had training and who had some background in psychology and health, and they had to be trained to be involved in the trial. So again, I've given a score of 3. Flexibility of experimental intervention and delivery. So the delivery of the intervention required them to complete a 5-session course in the app step by step, and This was done as one per week over a 5 to 8 week period, and uh, patients were given about up to 8 weeks, up to 3 weeks of inactivity, and they were then encouraged by these e-helpers to help them complete the intervention. And only after they have been inactive for almost 3 weeks, they were excluded from the trial. So the flexibility of experimental intervention in terms of adherence was good. So I have given a score of 5. So follow-up was also based on response to questionnaires on an online platform, and they have uh, followed up as much as they could, and so I've given a score of 5. Outcome was also that was assessed is relevant to the participants, which was reduction in the PHQ-9 and HUDA's score. So I've given a score of 5. An analysis was intention to treat, so I've given a score of 5. So in our case scenario, applying in our population using the precise tool, the this is the appearance of the graph. So I would say, uh, after using the precise tool, the concluded study is pragmatic enough or applicable in our patient population. Thank you.